Our next presenter is Donita Dylaram. Donita was in our 6-year oral maxillofacial surgery program at Kings County Hospital. And I'm sorry, I got the name where you are now. Down in Maryland? Where are you now, Donita?
University of Maryland.
Oh, there we go. Yeah. University of Maryland. Donita, while she was a resident with us, was a fantastic resident, as most of our residents are. We're very fortunate to be able to select people who are outstanding and always prove themselves. Donita's presentation is on head and neck oncology. She's been in a 2-year oncology fellowship down in Maryland, and we welcome you and thank you for coming this way. Let's give Donita a hand.
Peter, that was a great talk. I'm so proud of you too. Look how far. I remember you like 3 years ago when we were at Kings County together, so it's very good. So I wanted to share with you today what I've been doing for the past 2 years. And I've been in Baltimore. So when we all think of Baltimore, we think of The Wire. We think of homicide, life in the street. And actually, it's a little like that. Kings County pales in comparison to what I've seen. I don't think I've seen that many heroin addicts, homeless people in the streets of Baltimore. Compared to county, it's nothing. So, but it's not all this, actually. Baltimore has some good qualities. This is the Inner Harbor. There's lots of ship stock, and it's actually pretty. It's like a glorified South Street seaport. This is Harbor East, and actually my apartment's right here. And this is a view from my apartment. This is my future. If there's some Oncology thing, which we all know really doesn't. I do it because you love it. The other things that Baltimore have to offer, we have the National Aquarium. And it's actually pretty impressive. And those of you who know me know that I scuba. And I was able to dive in the Stingray tank about 2 weeks ago, which was a lot of fun. They have a symphony. They have Beethoven and Bach, and it's always nice to go. And our version of Broadway, this is what it looks like inside the Symphodrome Theater, just a few blocks from the hospital. Also, Baltimore is known for Ace of Cakes. And last year they had their first Grand Prix, so they closed off the streets, and there were Formula One cars racing. It's pretty impressive. I mean, I've never seen anything like that. We also have the Preakness, which is in every Prince, springtime, so that's fun as well. And Dr. Laza, this is for you. I had to put this in.
Camden Yards.
Camden Yards, yeah. So actually, beautiful ballpark. Home of Cal Ripken Jr., Iron Man, with his 2,131 consecutive baseball games. And we also have the Ravens and the M&T Stadium almost made it to the Super Bowl. One of the attendings for me have season tickets, so I got a pair when I first started. I was able to attend the game. What else is in Baltimore? Baltimore is home of the first dental college in 1840, started by Hayden. There's a new dental school, and it's actually, I was told now, the second most expensive dental school. It cost $140 million to build, some of it by the state. I think the most expensive is the one in Texas that they're building now. I spend most of my time, when I'm not operating, on the ground floor here where they have a faculty practice. And this is where we see most of our follow-ups and our pre-ops. I don't spend much time in the hospital dental clinic. And here we, for the past 2 years, University of Maryland. This is an aerial view. And attached to it is the Cali Shock Trauma Center, where they receive a lot of high-speed motor vehicle accidents from, and they chopper them all in to this hospital. Inside is actually quite impressive. It's kind of like the Bellevue Hospital where they build over the old facade. So this is all, it's like as if you were walking in the streets, and it's all built over. You can sunshine. Up here is the third floor. This is where the patient's waiting room, patient's family waiting room are. You can check in, they have coffee and cake, and they can call down to the OR and find out how you're doing. There's a fountain over here. It's very pretty. And here, there's a glass elevator going up to where most of my patients stay. The ICU, the surgical ICU, and all floors are located here. So the reason I went to Maryland were for these two, to be trained by these two people. This is Dr. Robert Ward. He's our chairman. And he's actually world-renowned, international, and written a lot of papers and textbooks. And he's one of the 3 pioneers for head and neck oncology by oral maxillofacial surgeons in this country. There's Josie Hellman and Dr. Dirks and Dr. Ward who started it. He was the first one to have a microvascular who saw the benefit of having not only an ablative surgeon, but having a reconstructive surgeon all in the same unit. So you never have to outsource and say, let's call plastics or orthopedics to put your free flaps in. This is Dr. Joshua Lubeck. He's my program director. He graduated from the Maryland program about 4 years ago. And so most of my microvascular surgery teachings and experience have come from him. Here is a picture of me, and this is Dr. Tao Zhang. He's a visiting professor when I was during my first year. He taught me some micro skills as well. And this is us, and most of our surgeries, once we put in our flap, are done under a microscope, 10x mag, and this is how we do it. It takes about less than 2 hours to hook everything up. But this is how we end up doing these surgeries. Well, I always wondered, like, why did they take me? Well, I came from this legacy. This is Kings County legacy. There must be something in the water in Brooklyn. Dave Kim, who I think it's more than 12 years now that he graduated, and he was the chief of Sean McClure, who was my chief resident when I was an intern. So, I don't know what they think. I think Dr. Wardall is happy to have one of us, and hopefully maybe somebody else will want to come in a couple years. And to tell you a little bit about myself, I come from this tiny country, Guyana, in South America. I came to the U.S. as a teenager and then lived in the Boogie Down Bronx. I was able to earn a full scholarship to NYU, and from there made it to Brooklyn at this fine place that made me an oral surgeon at Kings County. And then now I'm at the University of Maryland, where I did this fellowship that's 2 years. It's ablative your first year, at least that's how they try to structure it. Second year is microvascular surgery. We do about 250 cases, and this is just the oncology service. The 6-year, 4-year dual degree, 4-year program, they do another 800 cases a year. I did for my first year over 60 plus neck dissections, parotidectomies as they come in. I've done over about 10. Trachs, most of our patients, because we do such large resections and reconstructions, end up being trach. We don't do much of non-vascularized graft because they're such large defects and these patients need radiotherapy afterwards that you need vascularized graft. And I thought I'd put a breakdown of the numbers of free flaps, and it says parentheses 106 because one patient had 2 free flaps. They had fibula. There was a patient with Treacher-Collins syndrome missing his ramus and condyles, and there was 1 fibula made to ramus and condyles. But we do DCIAs, about 5. I did about 9 scapulas. Fibulas is the workhorse. We did about 49, 23 radioform free flaps, 15 ALTs, and then these ulnar, latissimus, and lateral forearms, which there's not much. You have much better and predictability with the ones above. My program director teaches like, you can pick a flap that you want, and I'll teach you that one. That's what they're getting in. So that's how we have those. So let's talk a little about ablation and reconstruction. I'll try to go through fast because I know there's someone else that needs to speak after me. These are all cases that I've seen. Patient with tongue cancer. Here is a patient being treated by a periodontist for periimplantitis, and obviously there's a large squame here. So large maxillary squamous cell carcinoma. As you can see here, significant buccal squamous cell carcinoma. This is the tongue because the squamous cell carcinoma has invaded the floor of mouth and the mandible. Here's another one in the retromolar fossa. And this is actually a salivary gland tumor. A high-grade mucoepidermal carcinoma that's just from the skin, from its supply. I'm going to talk a little about this. And I thought when I was asked to give this lecture that I would touch a little bit on statistics and the surgery residence here. I'd talk a little bit more about free flaps and just go over the basics of it so that when you're on set, maybe there are questions on it that you can answer. And then I'll touch about one thing that I hope to get a little bit more practice on, and that's robotic surgery, and that's something that we've started over the past year. A little bit of this is interactive, so I expect the surgery residents to speak up. So let's talk a little bit about statistics, and I'll go through these things pretty quickly. There's about, this is data from 2007, it's a little old, but there's about 34,000 cases in the head and neck of oral cancer. We see that in the mouth there are about 10,000. You see men still leading female in the incidence of these cases. If you look at, if you break them down according to race, you look at the 5-year survival, you can see that the African American race tend to do poorly. And the reason being is that they don't show up to have treatment until it's late in an advanced stage disease. So who, in Funk and all, and et al. In head and neck in February 2000, who had the highest incidence? Well, African American, those with lower income, higher grade tumors, they found mostly male. And by 10%, you already decrease your 5-year survival by 5 years. And we also found that age is really not an independent factor, but it's really what you present with. A couple myths about oral cancer. It's a disease of the elderly men who smoke and use tobacco and alcohol, and you should present with advanced disease. Well, that's not true. If you look at the faces of oral cancer today, you're finding that patients and young people under 40, that's the rise. And the implication is HPV virus. Well, HPV is transmitted by an oral genital route. And the genotype is really 16 and 18 because they cause more P53 mutations. And they're responsible for oral cancer, about 15%. It actually depends on who you read. There's a new article that says as low as 4%. Where they're implicated is oropharyngeal cancer, larynx, pharynx, base of tongue. So it seems that it's a cause. The good thing about HPV is that if you have an oral cancer or head and neck cancer that's HPV positive, you tend to do better with chemo radiation. And no one really knows yet why that's the case. Well, when you speak about oral cancer to your patient, you need to talk about staging. And staging tells you about prognosis. So you first stage by size, T1 to T4. T1 is from 0 to 2 centimeter, T2, 2 to 4, 4 to 6, and then T4 is anything that's larger than 6, larger than 8, but also invading bone or something that's not resectable. And then you talk about your nodal disease, whether it's one node involved, 2 nodes, are they on the same side, are they contralateral on the sides, and then you talk about is there distant disease. And then based on this, you can stratify and talk to your patient about occurrence and about overall survival. 5-year survival is on par for oral cancer if it's a stage 1 disease, about up to 90% survival. Stage 2, up to 70%, and when you get to advanced stage disease, you go down to about 50 to 30%. What are the things that give you good outcome? Well, stage, of course. Stage 1, stage 2, good outcome. Surgical margins. The only thing as a surgeon you have in control when you do these surgery is the margins. The neck disease is the neck disease. The cancer is gone where it's gone. The only thing you can do for your patient is to cut it wide and handsome. And you can do that because you have microvascular surgery, you have free flaps. No matter how big a hole you make, there's a way to fill it. You can get a free flap surgeon who can fill that space for you. Nodal disease, multiple disease or outcome, multiple neck nodes or outcome. If they're in the lower levels, levels 4 and 5, or outcome. And if the cancer is spread outside the node, that in itself decreases your survival by 25 to 30%. They also looked at perineural invasion and perivascular invasion. Those are all factors that about ablative surgery. Now I want to show you this. I've been kind of busy, not that fellowship hasn't kept me working too hard. I've actually had a new hobby. I do painting. So these are some of my paintings I'm going to put up. So if this doesn't work out, maybe I'll open a gallery sometime. Anyway, so as I said, as a surgeon, what you have and the thing that you can control are your margins. So the way we do the surgeries, and please, if you have any questions, you can interrupt and just ask me. You outline, use a marking pen, and you outline the cancer itself. So this is a cancer. I call this stage 1, as long as we've done a CT scan and there's nothing in the neck. It's a stage 1, because it's less than 2 centimeters. You outline it, and then you want to take a margin that's 1 centimeter around it. And you hope that when you resected this, that you've got nice clear margins, which will give you a good prognosis for your patient, and the clear margin is 5 millimeters. Close margin is anything between 1 and 5, and the literature is filled with what's close margins, what's clear. But this is the one we tend to use. And a positive margin is you've got cancer, so the margin you take is something less than 1. Well, what do we do about the neck? That's addressing the primary. You mark it out, and you cut with a 1 centimeter margin. That's how you handle the primary site. Well, what do you do with the neck? Well, if the probability of occult disease is more than 20%, you have to address the neck. And this is a person who presents with a small cancer, and when you palpate their neck in your initial exam, you didn't feel any neck nodes. So when do we decide this? Well, a couple of things that we look at. We look at the depth of invasion. So Byers and Sparrow and even Dr. Ward and Dr. Salama have looked at their depth of invasion and what are the incidence of neck nodes. And we found that if your depth of invasion is between 2 to 10, at University of Maryland we use 3 on the tongue, buccal, retromolar fossa, and if it invades more, of course. But on the floor of the mouth we tend to be a little bit, we use 2 to decrease the number because it's such a, not much of a transition to the neck. So you always worry about depth of invasion. It doesn't matter how small the cancer is. Okay, if it's a small T1, but it's deep, your chance of it getting into the neck is over 20%. And it's quoted about 33%. So if you're a betting person, for me, 33% is pretty high. I'd want someone to adjust my neck. But when you think about it, there's 66% of the time we're wrong. We're doing the procedure with 66% of the time odds that we'll never find something in the neck. But it's oral cancer, it's something that can really affect your mortality. So a lot of the patients, when we quote this and we explain this to them, like, adjust my neck. Also, the person who gets a neck dissection is anyone who has a tumor size greater than 2 centimeters. So T2 and above gets a neck dissection. And of course, if you need access for vessels for microvascular reconstruction, and you're going to be in the neck, you might as well do a prophylactic neck dissection. Now, when I say neck dissection, this is a person who shows up with a neck that when you palpate has nothing in their neck. And so you're offering them to adjust and resect the lymph nodes in levels 1 to 3 based on these ideas. Now, there are lots of controversies in the literature about the N0 neck. The N0 neck is a neck that has no palpable disease, or the neck that has, when you do a CT scan, you see nothing, no pathologic nodes on the CT scan. Or if you did a PET scan, nothing lives up in the neck. There are 4 studies. 3 of them, these 4 studies are prospective randomized study. 4 of them all say watch and wait. Well, Kligerman in American Journal of Surgery in 1994 looked at 67 patients, all T1 and T2 size oral cancer, and he looked at their 3-year survival. And he found that in the group that he just observed, watch and wait, he had their survival was about 50%. But the ones that he did the prophylactic neck dissection, they did better, 72%. So as surgeons, what do? We follow this study, and ignore the rest. Because we all are. We all want to operate, so. And I actually do believe this. So, what happens if you have a lymph node, a positive lymph node in the neck? If you have one positive lymph node in the neck, your 5-year survival decreases by 50%. If you have a contralateral lymph node, it decreases by an additional 50%. Like I said, if you have extracapsular spread, that's an additional 20 to 55%. So it's really important to address lymph nodes in the neck. Where do they go? Oral cancer goes to levels 1, submental region, levels 2, your submandibular, and then you go down the jugular digastric chain. So for most neck dissections in an N0 neck, that's the neck that you don't see or palpate any disease, you'll have most of your lymph nodes, if they were going to have disease, go to these lymph node chains from levels 1, 2, 3. And so that's your super omohyoid neck dissection. This is your prophylactic neck dissection that we offer your patients. There's a study done by Jaitin Shah, that showed the reason why we do these 3 and not to level 4 is that there's only about a 4% incidence you'll have metastatic disease in level 4. And level 4 is not an easy place to dissect because you've got your brachial plexus, you've got your phrenic nerve, you've got your thoracic duct. So you can get a lot of injury if you're not very careful. So, and then there's also your benefit of home. So that's mostly what we do for an N0 neck. Just to define elective neck dissection are those lymph nodes that you remove in levels 1 to 3 because you think that the risk of occult disease is high. A therapeutic neck dissection is all the lymph nodes that you remove because there's a positive neck node. These usually include levels 1 through 5. So it's called a modified radical neck. And that's when you do levels 1 through 5. And this is what it looks like when you do a neck dissection. You've got a big incision following one of the neck creases, and sometimes you can put an arm going lower just above the clavicle so you have good access. You can do, there are different types, and this is type 1, you preserve your spinal accessory. Type 2, spinal accessory internal jug, and type 3, you preserve all of your structures. In a radical neck dissection, this is what it would be, you took your SCN, you took your spinal accessory, and you also took your internal jugular vein. That's because whatever node that's present, it's so fixed to these structures that you can't safely remove them. Remove the mass without having to take these structures. I remember the first time I had to cut the lingual nerve, how I had to hesitate. The chairman I was working with said, come on, cut. So it's really unexpected change after doing all of this. And then a radical neck dissection, this is what it looks like really cleaned out. And you can see that you're missing your SCM. This is your carotid. You're right in the carotid sheath. You see your vagus nerve. And this is, of course, a patient with multiple neck disease, so there really wasn't any alternative but to do a radical neck dissection. What we do is when we have our specimen, we pin it out and outline the levels, but really you don't need to do that. You just put in the left oncologist because it doesn't affect you. So let's go over a couple more cases. This is another one of my paintings. So this is a 66-year-old female with a history of diabetes and hypertension. Smoked a pack a day for 20 years. And she comes in, she says that she has this ulcer in her mouth. So what information do you need? Come on, guys.
How old is it?
66.
How old is it?
Several months. Almost a year. So this is what it looks like. Well, first you need to know what it is, right? So you have to do a biopsy. Then you do the usual thing. Every time you guys admit a patient, you do the exact same thing, right? You do a biopsy because you want to know what it is, because you need to know the depth of invasion. Of course, I should start out first. You do your physical exam. You examine the oral cavity. You examine the neck. You do a biopsy to get your diagnosis. You do a history physical, and of course you want a CT scan. Right? You want to know how big this is, because it may be subtle, or this may be some nasty endocytic tumor that's deep and crosses the midline. And then you want to know what your next disease is. So, history physical, biopsy, depth of invasion is 5 millimeter. You did your CAT scan and it showed nothing in the neck, so you classified it as an N0 neck. So with 5 millimeter depth of invasion, and I told you more than 3, the risk of occult neck disease is greater than 33%. So I would offer this patient a partial glossectomy, cut this out, and then you can decide how you want to close it. You can just put the edges back together, or you can put a skin graft on it and bolster it in place. And I would offer a supramaldehyde neck dissection, so it's 1, 2. Right? And this patient is currently staged as a T2 N0 MX. MX because I didn't do a PET scan and I don't know that this is disease. And this is what it looks like. This is what it looks like. Someone took a sharp bite out of the tongue. But you can see she has pretty good mobility. She sleeps well, eats well. And this is what a neck incision started. They all look like they have a liposuction on one side. And they all ask, so can you fix the other side? It's a referral for the cosmetic practice that's part of this group. Anyway, here's another one. Chief complaint. There's pain on the floor of the mouth, and the pain radiates to the ear. Right away, you know, lingual nerve involvement. Remember your anatomy. It's a 75-year-old male, and these patients are sick. They all come in with coronary artery disease, and MI, hypertensive, diabetic. And you'll be amazed. It doesn't matter what this history is, a cardiologist will clear that patient for you to take to the OR. They'll say, high risk, go ahead and treat. And then you just have to deal with the complications that come. It's a cancer case. So everyone, your patients will always be cleared. And of course, this patient is a good smoker and drinker, 2 packs per day, 15 years, drinks a 6-pack every day. I can't recall how many patients went into DTs while being there for 2 years. You know, almost like you just automatically put them on DT prophylaxis. Anyway, this picture doesn't quite reflect it, but this is on the floor of the mouth, crossing the midline. It's indurated pretty hard, and it goes all the way to the retromolar fossa. So if you had to stage it, it's bigger than 2 centimeters, right? So it's a T2. So what information do you need? Pretty much the same thing. Thanks for speaking up there, Sean. Anyway, so you do your history, you do your exam, you do your history physical, you biopsy it, the depth of invasion is 6. However, when you do the CT scan with IV contrast, you notice this. This, of course, is an axial CT. The level of the mandible, as you can see here, IV contrast because these light up very well. Here's your internal jugular vein, your internal carotid, external carotid, and this here is a lymph node. This is your SCM. Every time you see a lymph node that's round off, normal lymph node looks like a jelly bean. And the 3 things that you look at when you look for a pathologic lymph node is you look for the rounding off, like that, so it's nice and circular. You look for a necrotic center. This is always a bad sign. So you see that little radio density, it looks a little darker in the center. And then if it's the size matters for lymph nodes. So for most lymph nodes in the jugular-digastric chain, if it's greater than 1 centimeter, it's concerning. Except for the jugular-digastric lymph node. The jugular-digastric lymph node has about 1.5 to 2 centimeters allowed to be that large normally. But if you look at any of those 3 signs and you look at your scan, you see that that's a patient that you now classify as an N1 neck. So what do we do? What's your surgical plan? Wide local excision. You cut this wide and handsome again. But how do you get access? This is a big cancer, goes all the way back to the retromolar fossa, crosses the midline. Most of these cases, you would either do a lip split mandibulotomy, so you make an incision up the neck through the lip, you cut the mandibles, so you can swing it open like a book, or you can detach the malahide from the floor of the mouth and pull it into your neck so you can see all the way to the base of the tongue, and you can have good Now, good access, so you resect this with good margins for the home. And of course, now, in this case, we did a pull-through. You've got this large defect, you've got this communication with the mouth, so you need to put a free flap in it to help obliterate that space. So this patient's stage is a T2N1, and this is what we did. This picture is the head up here. This is the mandible and the subplatysmal flap raised over. And this is the tongue after the resection. And of course, this is the neck dissection. This is the internal jugular vein that's exposed. Then what we did was we made, this is at the leg, and this is a thigh flap. And I'll go over the anatomy for the residents just to show you how to do these. And then you insert it and you create a new tongue. Of course, nothing, I want to stress, there's nothing, we don't recreate the function of what the tongue is. What's remaining does the function of this flap. The purpose of this is to help preventing it from being tethered to the floor of the mouth so that they could help with speech, help with swallowing, and of course to fill the space so that you don't have communication with the neck. And this is what he looked like. This is after chemoradiation. So he still has a feeding tube, and that's because with the radiation caused more fibrosis. He had a very difficult time with swallowing. Eventually, after swallow therapy, the multiple barium swallow block, we were able to get the feeding tube out. During that time, between this and the time he was able for his swallowing to wake up, he had to have a percutaneous pain. This is what the ALT looks like on your thigh. This is what the incision. It's a pretty long incision. I'll go over it. But this is how it looks when it's healed. And this is what his mouth looked like after the inset of the flap. It shrinks a considerable amount. And after chemoradiation. And this case was a picture that I showed you earlier. So this gentleman, I think he's in his 50s, history of hypertension, presents and says he's having a difficulty eating. He's really earned, and he smoked and drank for a long time. And as you can see here, there's this large squamous cell carcinoma on the floor of the mouth. And this is his tongue. It's so big that it displaced the tongue posteriorly. So what information do you need? Same thing, if you would treat every patient. So you did history physical. You can look at these at this point, you can almost tell the diagnosis right away. They all have similar clinical experience, similar presentation. You do a CT scan, and surprisingly, despite how large it is, there's nothing in his neck. And when you look at the bony window, he has bony invasion on both sides. So he's already a T4. He's already a stage 4. So he's a T4A and 0. I would definitely offer bilateral neck dissections because it's across the midline, it's quite large. And then because it's invading bone, we have to resect it. So his surgical plan, bilateral supraomahyoid. Remember, supraomahyoid neck dissection because it's an N0 neck. You don't need to go to level 4 or 5. Composite resection of the mandible. You want to get all of this, and in this case, because the erosion was close to the first molar, he got angle-to-angle resection, including a bit of skin anteriorly because it was close. He got a trach, got a peg placed, and he had a prefibrillar flap to reconstruct his new jaw. Like I said, we staged him as a stage 4, T4A and 0. And this is what it looked like. This is his skin flap raised up, his upwards, his head over here. This is the jaw with the cancer still in. We've taken part of the chin with the skin because it was so close. You can feel induration. This is what it looks like after you've taken out his jaw. And what's remaining is it's completely collapsed. And this is the specimen itself. Almost the entire floor of mouth, the whole mandible. And what we normally do is we take our neck dissection specimen in continuity. It really doesn't make a difference. There's lots of papers out there to say should you take your neck dissection in continuity to the primary cancer. And the thinking was that you're taking those cells that's in transit from the floor, from your primary site, you're taking those cells in transit continuity or discontinuity. They're just case reports that show that maybe, I think there are about 2 or 3 case reports in the literature that shows that there have been cases where things have been left in the sublingual gland. In any event, this is what we did. And this is what it looks like. This is his fibula flap reset into his, to make a new mandible. We all use reconstruction plates. I should tell you that all of our surgeries where we do bone grafting, we do a lot of medical modeling. The CT scan of the patient is uploaded in the computer. Then we do virtual surgery. We sit at a computer with the person behind the screen, and it's all with surgical modeling. We say, this is where we need our cuts. We want to make one osteotomy in the fibula. Can you make me a cutting jig for it? And so they'll mill a cutting jig for you, so you know what your wedge osteotomies are in the fibula. So you know that when you do those wedge osteotomy, you take a little wedge, because it's a long bone that you need to make into a U shape. It tells you exactly where to cut. And they can pre-bend your bar for you, but my fellowship director says, why would you pre-bend the bar when you're fellows? So we pre-bend the bars and have them sterilized on the day of surgery. And all of this stuff is all done prior to the patient getting into the OR. And this is him with his new jaw inset. This is him after after radiation actually, because he didn't reach criteria for chemotherapy. So you can see we made him a pretty decent jaw. You have to realize he's then, after this surgery, after 6 weeks of healing, he had 6 weeks of radiation therapy. This is the skin here. This is the skin from his leg, because we had to take part of the skin from his chin because it was close to cancer. And this is what it looks like inside. And he's now on board. If he wants to have implants, he can have implants because this is a vascularized bone, so I would put implants in this case. This is what it looks like if you were to look at a 3D model of what the surgery looked like. So this is his new jaw, the fibula bone with 2 osteotomies. Functioning pretty well. So let's switch gears a little bit, and we'll talk about reconstruction. A lot that I've spent my last year doing. This is when I was going through my Van Gogh phase. It's not one of my paintings. So we're going to talk about free flaps and what are your options. And this is probably what, if we're going to ask you questions in your own set, focus maybe more on the upper 3, but perhaps the last 2. For soft tissue, your soft tissue options, there are plenty, but the ones that we use mostly are your radial form free flap and your anterolateral thigh flap. For bony options, you can use your free fibula flap and your deep circumflex iliac artery free flap. And then the last choice, when there's no other body in the bone to use, you have your scapula flap. Your scapula, you can actually use it just as a soft tissue because you can take a lot of skin. It's amazing how much skin you can take from the back and still close it primarily. So we can use that as well. So let's talk about the radial form free flap. Now we'll go through fairly quickly. You have to know your anatomy. So I can remember like going through dental school. I'm like, well, I'm going to learn about the arm. I remember never learning about the legs and stuff. But you've got to know your anatomy. The good thing about Maryland is we have a cadaver lab at our disposal. Whenever we need to, if you want to review this or you want to just practice your neck dissections to get more competent, you can just ask us. I ask the secretary, I need a cadaver. The next day it's there for me over at the medical school. We also have a microvascular labs where we have rats, and you can sedate the rats, and then you do the femoral cut downs, and we practice the microvascular technique on these rats. So there's lots of opportunities to learn outside the OR stall. So 2 muscles you need to know, your brachioradialis muscle and your flexor carpi, because if you have a radial forearm, your pedicle goes right here. So as you can see here, you have your radial artery and of course your ulnar. But you don't do ulnar flaps because your ulnar artery is right with it and you can end up with injury. So before you even consider doing your radial forearm free flap, you do an Allen's test to make sure that if you take one of the artery, you don't end up with the ischemic pain. That's not good. And then you have to know your venous system. Most of the radial forms that we harvest, we take a cephalic vein with it, because the radial artery comes with its venae comitans, and there are usually 2 of them, but they're very small. If you look at the diameter, it's only about 1 millimeter. Those are very hard to couple. The cephalic vein is about 3+ millimeters, and so it's nice to have this little device that you can couple the veins together. And then, of course, you need to know your anatomy. So you have your brachioradialis, you have your flexor carpi muscle here, and then you have your palmaris longus. Palmaris longus is a good muscle, and then the tendon is actually good to know, because you can take that tendon or part of the tendon and use it to recreate a lower lip. So if you had a patient with needed a complete lip resection, you can use the palmaris longus tendon and sling it up to your arches and have a pseudo lip, even though it's non-functional, but you can have a shape of a lip. And then, of course, you have your flexor carpi ulnaris on the by the female side. So this is what it looks like. You determine how much tissue you need, and you mark that out, and then you harvest the radial artery with its venae comitans, and this is the cephalic. And this is the tissue that you take to recreate your tongue or your floral mouth or your cheek, whatever soft tissue you need to replace. This is, once you turn the flap up in this area, this is what the bed looks like. And then most of the time you close this primarily, and then you have a skin defect, because your flap really is composed of skin, fascia, and the subcutaneous tissue between. We don't do radial osteocutaneous flaps because you can only take 20% of the bone. It's prone to fracture, and the bone's not good enough to put in on certain things, so we just never do it. You have such medical, you have better options for bone reconstruction. And this is what it would look like. So if you have a tongue defect of this size, you can inset your radial forearm and recreate the tongue for the reasons that I've explained earlier. Most of the time we put a penrose within this so that if it's still oozing a little bit, you don't have a hematoma that can compress your veins and then your artery, and you would have a loss of the flap. Because these patients, these free flap surgeries take, you're looking at a resection, a neck dissection, a trach, harvesting of the flap, inset of the flap. It takes about 10 hours to do these. They could take even longer. And you're not only talking about a primary site, you're talking about an additional donor site. So we are very, very, very watchful and vigilant when these patients leave the OR. And so we always take measures on monitoring and how we care for these patients to prevent an additional trip to the OR. I wanted to show you a picture of what it looks like, and it's kind of hard with this little thing here, the coupler that I keep mentioning. It's a little device that you put the veins, the 2 ends of the veins inside, and as you close it, it comes together. The artery, you hand sew. I'm using 90mm suture, and you just hand sew. You put the stitches about 1 millimeter or less from each other. This is an example of what it looks like in the mouth, and this is what his arms look like when he heals. Anterolateral thigh flap. You have to know your anatomy. Usually it's between the vastus lateralis muscle and the rectus femoris muscle up here. And the pedicle is based off of your lateral circumflex artery, which comes off your profunda. And what you can take, I'm going to go through quick in the interest of time. You can take skin, you can take fascia, but you can also take a part of the vastus lateralis. And usually the only thing the patient complains about for these surgeries is that they have difficulty walking upstairs. And it's a pretty low morbidity site. So for a tongue that you've resected more than half of, you need a bulk of tissue to help with not tethering it and function. You can place the forearm, the ALT flap in there. This is what it looks like after radiation, and this is what it looks like when it's healed. Free fibular flaps. For the anatomy here, it's the non-weight-bearing bone, and what you do is you preserve 6 centimeters centimeter from the ankle and 6 centimeter from the knee, so you get stability of the of your foot. And you can take this bone with its blood supply. So with the muscles that you really need to know are your peroneus and your soleus, because it's this septum that your perforators travel, so that if you need to take a bit of skin on this leg, that you have those perforators that would supply the skin portion of your flap. It's based off the peroneal artery, which comes off the posterior tibial artery, and this is all off of the clidial. So the clidial comes one step bifurcates into the anterior tib, and then you have your posterior tib, and your posterior tib gives your peroneal artery. Before we do any of these flaps, the patient gets an MRA or CTA of the leg, because most of our patients are older, they all have arthrosclerotic disease, and you want to make sure not only that if you take a vessel from the leg that they have good function afterwards, but you also want to know about the vessel that you're taking. Because if they have good arthrosclerotic disease, when you're dissecting your vessels, they tend to fall apart and the intima separates the adipose tissue, and you can end up with complications down the road. So an example of this, here's a patient with, here's the medical modeling with a large ameloblastoma involving, by the time you resect it, you'll take the condyle and pretty much half of it. So you send it to medical modeling, they make you these really fun jigs that you can put on and say, we're here. This is what the specimen looked like, and now you have this big defect. There are multiple ways of reconstructing it, but more than 7, if you do Cabral, you have an increased rate of bone loss if you do a non-vascularized flap. We offer him a free fibula flap, and this is us harvesting it. We usually map out the patient's asleep, an outline of what we're going to do. And here's the flap harvest. And because we have our models and we have our cutting jigs and we've pre-bent the bar, you can cut do the osteotomies in the fibula and pre-plate it while it's still pedicle to the leg, so it's not an ischemic flap. And then you can inset it into the neck. Your deep iliac circumflex artery is essentially your anterior hip graft, but it's really wide open. So it's the same anatomy as your anterior hip graft. It's based off of you take the anterior hip part, it's based off of the DCIA. And what you need to remember is if you want to take the internal oblique muscle, you need to find your ascending branch. Almost always, we end up cutting the iliohypogastric nerve because it goes over, and everyone complains of the numb hip groin. We try to preserve the lateral femoral cutaneous. This usually runs underneath the inguinal ligament. Then, of course, this is what your graft would look like. You have bone. You can take skin, but it's so thick on the hip that usually we don't do that. And you can take the entire internal oblique muscle if you find this ascending branch. And then, of course, you have to go medial to find your iliacus, so because the pedicle runs right between your iliacus and your transverse abdominis muscle. Risk for this, one of the major risks is that hernias. Be very, very careful. You have to choose the right patient. And they all wear abdominal binders for about 3 months. They can't wear more than heavy, 5 pounds. These are the flaps because you get a real good chunk of bone, and this is what it looks like. It has a short pedicle, but you have good height and good width of bone. This is a defect from the hip. But as you can see here, when you inset it, it's actually pretty good height with the mandible. And Dr. Berger, I placed lots of implants in my last 2 years, but unfortunately none of them have been in the regular mandible. They've all been in DCIs.
We'll give you credit for it.
And for all of these, Peter, I have to flap them because I never know where the blood supply is. So they get flapped. And then lastly, scapula flaps. This is our last resort. If you can't find a bone anywhere else, you can use the scapula. The one case that we did was the patient had poor legs. They had axillary fem bypass bilaterally, so we had no other choice. You have to know your artery. It's based off the subscapular artery. You harvest the circumflex scapular artery. The muscles that you really need to know are your triceps, your tricep, your teres minor, and your teres major, because that's where the pedicle comes out. This is a patient who had bronch, and as you can see, she has an orocutaneous fistula. Who's been using IV bisphosphonate. She has a pathologic fracture here. And we offer her a scapular flap. So surgery because it's a new thing in head and neck oncology. It'll take me just a few minutes. TORS means transoral robotic surgery. Moore et al. In laryngoscope in 2010 says the advantages of it is that you avoid large facial splitting procedures. Because you imagine some of the cases that I showed, you have to do a lip split, mandibulotomy, and do a pull through into the neck. They can be highly morbid. And it's an alternative if you have a base of tongue cancer that's small for T1 or T2, which normally you can offer your patient radiation and chemotherapy. You can also offer them on resect tumor and you can save the radiation for later. Because radiation is a gift that you can only get once. Once you've had radiation, you can't re-radiate the tissue because they've already reached toxic dose. And you can also de-intensify adjuvant treatment. And it's a good quality of life. And they've found that if you use TORS, patients that need gastrostomy tubes are 10% rate compared to conventional lip split, pull through, can be as high as 40%. So Cohen showed that his outcome with TORS, he looked at 50 patients, looked at the first and second year of survival, and they were actually pretty good, 95 to 80%, which is on par with conventional surgery. What is it like? This is me at the TORS. It's really a robot. This is Dr. Lubeck. You can sit in the corner. It's like playing video games. And then you have your assistant at the head. So this is the robot with the arms that goes into the oral cavity. And you have this big glorified Dingman retractor, and then you have the arms, and this is what they look like. You have little pinchers and pickups in the arm. The middle port is a camera.